right? Of course we have personal experiences and we should have those experiences. The challenge comes when I walk into a patient's room as Dr. Stubbe and I give her advice based on my personal experience with one of my kids. And I don't own that with my kid, my second kid still doesn't live tonight, he's 15. And so when I start talking about sleep, I get really emotional about it. But I need to own that I'm talking about my kid, not about sleep in general, which is a hot topic, let's face it. But I need to be really careful about that. So here are my boys a while ago. This was 3 weeks after I started working at UNC. Thank you, Dr. Menard, for giving me maternity leave when I barely started working here. And this picture's taken, I think this is postpartum day 2, and what you may not appreciate here is that I'm really, really anemic. I had an uncomplicated, unmedicated, wonderful hands and knees birth, followed by 18 hours of bleeding. And I kept saying, I think I'm bleeding. I'm like, oh, you're fine. I think I'm bleeding a little bit more than normal. Oh, don't worry, you're just fine, you're fine. And so finally, when I got up to the bathroom and had a vagal episode and like there was a crime scene on the floor, they sent a crib, and it was 18. And I told the story because I couldn't be more privileged than to be a new faculty member at an academic medical center, and people didn't listen to me. I knew something was wrong and people didn't listen. And I think one of the core themes that we want to share today is how critically important it is for us to listen to every single patient. My story ends with a transfusion reaction and I created 20, but it was all fine. But if we look at transfusions over the last 20 years in the United States, we've seen this remarkable increase, 400% increase in the rate of women being transfused after giving birth. We know that hemorrhage is one of the leading causes of maternal mortality, and that 70% of maternal deaths due to hemorrhage are avoidable. Overall, 63% of mamas who lose their lives in situations that could have been avoided with appropriate care. And so we are letting 2/3 of these women die by not providing appropriate care. This is from the Maria review of 9 states maternal mortality reviews, and they talk about the fact that provider factors contribute 31% to hemorrhage deaths. The most common class of provider factors was assessment. 1/3 of the time, the provider did not appropriately assess the patient. And the reasons for maternal deaths were delay in diagnosis and effective treatment, misdiagnosis, and ineffective treatment. So I think we are not doing a good job. And part of that is by ignoring signs and symptoms, and part of that is not listening to women. And so I want to lift up as a goal for the work that we all do every day, a quote from Chanel Portia Albert, who's a doula in New York City. And at the Decolonize Birth 19 conference weekend before last, she said that she wants every patient to be able to say, I am seen, I am heard, I am loved. What would our care look like if we made sure that every single woman and every family we cared for was seen, was heard, and indeed was treated like a loved one? I think we're not doing that right now, and we need to change that. So now I want to zoom in on the specific aspects of these issues in the 4th trimester. So we'll talk a little bit about the developmental and evolutionary rationale for a 4th trimester, about some of the unmet needs that mothers have. And then I want to talk a little bit about how structural racism and implicit bias contribute to inequities in 4th trimester health. I am clearly a privileged white woman. I do not have an experience of implicit bias or systemic racism, but I'm trying to learn. I would urge those in the room who have that lived experience to call me in or call me out if necessary, because I want to learn to talk about this better. And then I want to talk about some recommendations to improve some. Is Dr. Cohen here? I would be very happy to yield the floor. No problem.
Okay, hi everyone. I'm bursting in because I love you all so much. And thank you. I'm sorry to interrupt your wonderful story, but minutes. So hi, Mandy Cohen, I'm the Secretary of Health and Human Services. Good to see so many friends, and I know all of you have been working on these issues for so long, and it's really important for us to continue to gather like this to make sure that we are plotting a course that I can actually make a difference as we look into the future here. We have a lot of champions in this room that I know have been working on this for a very long time, and I wanted you to know that at the state level, this is of the highest priority for me personally, and the work that we're doing at the state. Not only does it align with our work in our early childhood action plan, which has maternal health and child health specifically, and intentionally, particularly around the disparity in infant mortality from those who are born white here and those who are Black. It's an atrocity, and we need to address it. And so not only does it align with all of our work, I know that we all have the levers to actually make change possible here. One of those levers that we need some help on, and that's Medicaid expansion. And I'm sure that many of you have seen the evidence that shows that in expansion states, they've actually made some real progress on infant mortality, while those of us who are non-expansion states have actually gotten a little bit worse. Sad, right, that we are not utilizing a tool at our disposal to really help our moms and kids and really our state get off to the best start. So obviously it's live and active issue right now, which is why I can only stay for a few minutes here, but we really, really need this tool of Medicaid expansion if we're really going to make work faster. And recognize how much work is going on. I want to acknowledge our department. So I see Dr. Kimball, who is here, Dr. Wilson from my team, and others who have been leading work, particularly around the perinatal system task force. I want to go on that work. So I want to make sure that we are aligning all of these. I think that's why it's important we're coming together, because there's a lot of, like I said, good work happening, but there's really childhood action plan, these task forces, what we're going to be doing with our maternal health innovation grant, and we want to make sure that we are all aligning to really drive better health for moms and babies. I will say that that starts with mom having a pregnancy when she wants to be pregnant, right? That means access to contraception. Deciding when she wants to get pregnant, an entire period of teen pregnancy. We know healthy babies start with healthy moms and healthy families and healthy communities, right? And so how do we think about wrapping all of our resources around folks, and not just at the time when yay, they happen to join us in the world. So right, we have to think about that upstream. So thank you so much for all the work you're doing. Make sure you're working hard with our partners that you have here in the room and the state, and help us get Medicaid expansion, because that's really going to be a tool we need in order to actually move the needle here. Okay, I'm going to turn it back over to your wonderful story. Sorry to barge in. Thank you for all the work you're doing. Okay.
So now we're going to talk a little bit about and I'm going to talk a little bit here about evolution, which is not my area of expertise, but I'm privileged to work with Kristen Kelly, who is a PhD anthropologist who's talked an enormous amount about how it is that human parent lives the way that it is. So we're going to go a little nerdy for a second. When we think about strategies that different mammals have for taking care of their babies, some mammals are what's called altricial. So these are little mouse pups on the left, and when mice are born, they're hairless. Their eyes are fused, their ears are closed. They can't do much other than sort of find mom and latch onto her in nurse, but they're pretty much helpless. And these altricial species tend to be called nesting species. So a mother mouse will feed her pups and then leave them all clustered together and go off and forage and then come back and feed her pups again. That's very different from what are called precocial species. So this is April the giraffe on the right. How many people followed April's pregnancy and birth a couple years back? So April was being live streamed during her birth. That seems like maybe an invasion of the violation. Is there a giraffe? But nevertheless, this is April's baby at about an hour of life. And if you're a baby giraffe, you have to be able to stand up and keep up with the herd pretty much within an hour. And so horses and giraffes and other herd animals are pretty much on their feet and able to walk pretty fast, almost immediately at birth. And So they're called precocial. They're sort of ready to fend for themselves. And humans don't really quite fit in either category. This is my niece Ayla when she was about 2 weeks old. She's now 4 and much more dynamic. And her eyes did open a little in this picture. And she can certainly make noise. But she needed to be carried and held all of the time. And so human babies are incredibly dependent, not quite as dependent as those rat pups, but really dependent. And yet they are able to interact socially and do things that seem more precocial. So they've been called secondarily altricial. And there are lots of theories about why human babies are born so immature. There's a wonderful book called Costly and Cute that is written by a group of anthropologists helping to understand human birth and parenting. Everyone in this room would probably love it, so check it out. But one of their really fascinating theories is that being born immature means that much of human brain development happens with that baby on the outside. And that means that baby is seeing social cues, that baby is hearing words, that baby is learning language. And so it is an advantage for us as cognitive creatures to grow our brains interacting with other human beings. So one of the reasons babies come out so early is to have that brain development on the outside. And I think that's really important when we think about equity and social justice, because those mothers who aren't able to take leave and have to deposit their baby in a car seat in the corner and can't have those interactions, we are depriving that baby of its developmental birthright by not allowing that baby to be cared for virtually. Not to mention we're depriving that mother of her recovery from birth. So one of the other things that makes us different from the other great apes and primates is illustrated here in this picture of this mama gorilla. So you can see a baby gorilla is hanging on to mom. And it turns out that all of the other great apes, the babies have prehensile hands and feet. The babies still have that grasping reflex. The pediatricians in the room know we evaluate that, right? But a human baby can't hold their whole weight with those hands. And a human mama does not have a great chest. And so we can't carry around our babies and go about our business at the same time without some kind of assistance. And so in order to solve that problem, humanity had to come up with a couple of things. One of those was the village. There have to be other grown-ups involved in helping care for that baby and that mama. In fact, the reason they're so cute and they're not horn scrawny like rat pups is so we can get the other grown-ups to help. Because if the baby's not cute, then mom's stuck taking care of it all the darn time. But if the baby's really sweet, then some other people might want to help out. So moms need that village. We're wired to have that village. We're collective breeders that must have other grown-ups involved in caring for our babies. The other thing humans did was to invent the sling. So the baby carrier may have been the first human invention. Because you can't hunt and gather and carry a 8-pound newborn in your arms and survive very long. So we needed a way to carry our babies. And in many traditional cultures, babies are born all the time and they can suckle whenever they want. So that mom doesn't breastfeed every 2 hours, every 3 hours. That baby just breastfeeds whatever, and the mom goes back to business. So that's a lot about the baby aspect of the 4th trimester, but there's also a maternal aspect. And it was Sheila Kitzinger, who was a childbirth educator and feminist in the UK, who wrote way back in 1975, there is a 4th trimester to pregnancy and the neglected at our peril. She went on to write, it is a transitional period of approximately 3 months after birth, particularly marked after first babies, when many women are emotionally highly vulnerable, when they experience confusion and recurrent despair, and during which anxiety is normal and states of reactive depression are commonplace. What's striking about this is this was written 44 years ago. And I would argue that the trajectory of postnatal care for women has not been steady improvement in the last 44 years. If anything, women are more isolated and abandoned than they were before. So what are some of the challenges that mothers face? Well, we're here in part to talk about the maternal mortality crisis. And we know that more than half of pregnancy-related maternal deaths occur after the day of delivery. So if we're going to address maternal mortality, we have to address what happens to that mom after the baby is no longer inside of her. And so it's critically important that we identify those moms at high risk, that we plan for their follow-up after discharge from maternity care, that we have touch points to keep up with them throughout that first postpartum year, and that we expand Medicaid so that they do not lose their insurance at 60 days postpartum. So thank you, Dr. Cohen, for going back to the State House hopefully to get that to happen today, if possible. There was also substantial morbidity for moms in this time period. And these are data from Listening to Mothers 3. It was a survey of women across the country about the major and minor problems they faced after birth. And it will surprise no one in this room, as we've all been through real of babies, but sleep loss is the biggest problem that mothers face. 1 in 5 women report severe problem. Sleep loss is a major problem in those first 2 months. And another 2 in 5 report it as a minor problem. But mothers also feel stressed, they're exhausted, they worry about weight control, they worry about lack of sexual desire, sore nipples, feelings of depression, heavy bleeding. There's a lot going on with these mothers. And for the most part, until recently at least, the standard of care was, well, we'll see you in 6 weeks, good luck. Let us know if you need anything. And that's simply not sufficient. So when we think about the support that we do provide to mothers, I'd like to say, deliberately provocatively, that if the baby is the candy and the mother is the wrapper, once the candy is out of the wrapper is cast aside. I really think that is manifest in the fact that the child gets seen 2 days after discharge, a week after discharge, and 1 month, and 2 months, and moms get, good luck, we'll see you in 6 weeks if you come. Take care. And that mom is recovering from a lot, right? She's either pushed out a baby, which means some things are stretched differently than they usually are, or she's had a laparotomy, which is major abdominal surgery. One of my friends had a C-section for her first baby, and she said, since when does the doctor cut you open and not even talk to you for 6 weeks? I was like, oh, interesting question. I think I did that yesterday. But I think that that's our standard of care. And that's really, really not acceptable when we think about it. We also know that a substantial proportion of women are never seen after they deliver. One of the HEDIS measures is women completing a postpartum visit at 21 to 56 days postpartum. What we see here is that for commercial PPOs and Medicaid HMOs, somewhere around 30 to 40% of women never have a postpartum visit. So they birth a baby and go out into the world, and then we don't even talk to them. And I think that some of that has to do with the absence of paid leave and paid sick leave. So if you're back at work and you have to take unpaid leave for half a day to go to your postpartum visit, you might decide that earning $10 an hour for 4 hours is worth more to you than that visit. That has something to do with the fragmented nature of care, that has something to do with perhaps the fact that we're not giving people what they need. In listening to mothers, women were asked to what extent their maternity provider gave them enough information about a series of topics. And you'll see here that on the bottom of this list, the only thing that reaches 60%, which is passing, right, is what birth control you can use after giving birth for midwives. The obstetricians and family doctors don't get to 60% of that. But what's kind of stunning about that, aside from that being really troubling, is that at the top of the list is changes in your sexual response and feelings. And there, folks are below 40%. Family doctors make it to like 55. And if you're going to talk about birth control, you kind of need to talk about sex, right? Like the birth control isn't just to be on birth control. It's because you are going to potentially do something to get you pregnant, and you might want to talk about that a little bit. And then there's how long to wait before becoming pregnant again. And here again, we're at 50% or below. Well, if you don't know that birth spacing is a thing, how are you supposed to be interested in the birth control? So we're not providing women the information they need to even realize why they should be using this birth control. And in doing so, we've reduced her to a thing that can get pregnant. We don't want that, so we're going to do something about that and forget about the rest of it. And so I think it really speaks to a discounting of the importance of women's lived experiences if all we do is give them a birth control method and set them on their way. From listening to mothers, 1 out of 4 women did not have a telephone number of a care provider to contact when they were discharged from the hospital in the first 2 months after birth. 1 out of 4 did not know a phone number. Now we got to get to the phone number being answered and the person answering it knowing something, but they don't even have the phone number. And so that's sort of the level where things are right now. And I think that I'm delighted that Kristen Tully and I and Carolina and Kelly from NC State are about to launch a project to redesign the postpartum discharge process. And then we'll start to look at, well, maybe that phone number should be in big letters at the top of the discharge summary, not on page 37 of the 72 that you were handing on your way out the door. But this is the situation where women don't even know who to call. So what are the consequences of this lack of care? So when moms don't get support, they're likely to stop breastfeeding earlier than they want to. The cessation of breastfeeding is associated with more risks to babies and to moms. Mamas who don't have information about pregnancy spacing or access to contraception are more likely to have a short interval pregnancy. Mamas who aren't seen will have, by definition, undiagnosed depression and anxiety if they have depression and anxiety. And if that's not treated, that affects their well-being profoundly. That also affects their baby's well-being and development. And then those short interval pregnancies without adequate interconception care increase the risk for preterm birth and mortality for the next baby. It was in recognition of all of these factors that Dr. Heywood Brown, who was president of ACOG, convened a group to redesign postpartum care. And what this schematic tries to show here is at the bottom, the traditional model was the 6-week postpartum visit. And the logic of that, people said, well, where did 6 weeks come from anyway? And one of the senior people at ACOG, Dr. Hal Lawrence, who I believe is very familiar, told me, well, that's from the Bible, because Mary took Jesus to the temple at 40 days postpartum. I thought, well, that's interesting. But actually, in Leviticus, there is language saying that boy children should not be brought out for 40 days, and girl children had to be kept home for 80 days because girls were unclean before they could go out into the world. And so the 40-day postpartum visit sort of comes from, now that you've been let out of the house, you can go and get blessed by the healthcare system. And this isn't just in the Judeo-Christian tradition. In Latina culture, there's the tradition of La Cuarentena, which is a 40-day period of rest and care. In Asian cultures, they're doing a month. So there's something about a month to 40 days that mothers are supposed to be recovering from birth. And in all these traditional cultures, that means grandma and auntie and neighbors are all coming in and helping and taking care of that mother, taking care of that baby, so that that mother can heal and recover. And if all of that's happening, then maybe it does make sense to come out into the world at 40 days postpartum. But if you're trying to be back at Target in your skinny jeans for your Snapchat photo at 5 days postpartum, like we've ditched all of that care and concern, and we've just said good luck, muddle through, we'll see you in 6 weeks. So what this ACOG recommendation was that all women should have some contact with their healthcare provider in the first 3 weeks. And we very deliberately didn't specify whether that was an office visit, because it stands to reason that getting your baby in the car seat in the car and getting yourself to your OB's office and sitting in the waiting room for 45 minutes and then being told, how are you doing? Great, go home, is not the best use of people's time. But that could be a home visit, a phone call, that could be a text message, that could be interactive telehealth, but we should be checking in on moms proactively and not expecting them to call us. Don't call, we won't call you, you call us is not really a very supportive posture to take. There are moms who need early follow-up, particularly mothers with hypertensive complications of pregnancy need a blood pressure check to avoid hypertensive crisis and stroke. And then there are other high-risk folks that may benefit from a more formal contact at 1 to 3 weeks. But through all of this, instead of this one-off visit, there is a primary maternity care provider who is responsible for that mother over the sort of 8 to 12 weeks of postpartum recovery in the 4th trimester. That's the model that we hope to advance with ACOG. And then at some point between 4 and 12 weeks, when mom feels ready and better, she will have a comprehensive, you are blessed to go back in the world kind of postpartum visit. Some moms may feel great at 4 weeks. Other moms may not be ready for that till 12 weeks. And instead of expecting everybody to do it at exactly 42 days, we would be flexible. So now I want to shift gears a little bit and try to talk a bit about structural racism and implicit bias and how they contribute to inequities in the 4th trimester. So I believe all of us in this room are familiar with the egregious inequities in health outcomes for both mothers and babies in the United States, with non-Hispanic Black women having 3 to 4 times the risk of dying due to pregnancy-related causes than non-Hispanic white women, and with a similarly marked increase among non-Hispanic Black and then American Indian Native, American Alaska Native mothers in terms of infant mortality. I think it's important to appreciate that these inequities have to do with differences in the ways that we as a society value different women. This is a quote from Lisa Harris and Ted Wolf, running on stratified reproduction. Throughout the U.S. history, the fertility and childbearing of poor women and women of color were not valued equally to those of affluent women. And there is a long legacy of laws and policies and procedures that differentially treat white women and Black women and women of color when they are pregnant, and those are continuing to manifest today in the disparities in outcomes that we see. It's to address these inequities that in the 1990s, a group of women of color came together and created the notion of reproductive justice. Reproductive justice is more than reproductive rights. It's sort of the merging of reproductive rights and social justice. And in a reproductively just world, every woman would have the right not to have a child, so access to appropriate contraception, the right to have a child, if she so desires, and the right to parent children in safe and healthy environments. So it's not enough for someone to have a baby and then be sort of drop kicked into the world saying, figure it out, we're so sorry that you live in a household with Black women and with no resources and exorbitant rent and insufficient support. And I think a key tenet of reproductive justice is that so often in our neoliberal society, we believe that bad outcomes happen because of bad choices by individuals. But individual choices have only been as capacious and empowering as the resources anyone can turn to in our community. So if the community resources aren't there, there isn't really a choice. And we need to be mindful and take advantage of that issue of change. Dorothy Roberts has written about this extensively. This is another fabulous book. They say we don't need to spend any money on social welfare programs or figure out racism and poverty. The solution is to keep these people from having children. And I think as we move toward increased access to LARC and pregnancy planning, which is incredibly important, critical to enable women to decide whether or not to have children, we have to make sure we're not telling people don't have children because you're poor and only wealthy, well-to-do people are allowed to reproduce. Because there is this sense in a lot of American policy that it's a class privilege to have children, and if you don't have that, those resources, then you really shouldn't be doing it, and that's not acceptable. It's also important to appreciate that health inequities are differences in health that are not only unnecessary and avoidable, but in addition are considered unfair and unjust. Health inequities are rooted in social injustices that make some population groups more vulnerable to poor health than other groups. And I think this definition comes from the Boston Public Health Commission. I think it's really important to recognize that when we see health disparities, they are often the result of very deliberate social policies that may date back 50 or 100 years, but are still manifesting themselves today. And to the extent that those social policies created those health inequities, we need to create social policies to uncreate them and to take those health inequities away. And that's why I think it's so exciting that one of the core tenets of the perinatal plan in North Carolina is to undo racism, which is not easy, but which is critically important if we're going to create actual equity. So Joya Perry, who's one of my sheroes, introduced me to this fun fact about the history of healthcare in the United States. So when Medicare was introduced in 1965, Part A, which is the Medicare we're all familiar with, was a hospital insurance paid for by Social Security payroll tax. Everybody in the United States in every single state had the same Medicare access. There was a Part B problem piece for doctor's visits, but then Part C, which was the part for poor people. We're matching funds for states to provide medical care for low-income AFTC beneficiaries. And that meant the states got to decide how generous they wanted to be. And that reflected the fact that there were some states, predominantly in the Southeast, that didn't really want to be generous to poor people because they thought those poor people didn't deserve generosity. And they wouldn't vote for this bill unless they got to control exactly how it played out at the state level. And so those aspects of white supremacy went into how Medicaid came to be, and are the reason that every state has a different Medicaid policy. And that is affecting people today. That decision in 1965 means that those areas without Medicaid expansion have the highest proportion of non-elderly Blacks. And so uninsured non-elderly Blacks are more likely to fall in the coverage gap because a greater share live in states that have not implemented Medicaid expansion. So the racist policies of the 1960s are playing out in the everyday health of the folks living in these states here in 2019. And I just want to talk for a second about the issue of pregnancy Medicaid. So in every state, pregnancy Medicaid is mandated to be offered to folks up to 138% of the FPL. But most states will offer pregnancy Medicaid coverage at a higher level because they appreciate that it's a good idea to get prenatal care, which is good. So in North Carolina, it's at 201% of the FPL is the cutoff to qualify for pregnancy Medicaid. But at 60 days postpartum, that pregnancy Medicaid goes away. And if you're a parent in North Carolina, you have to be earning less than 42% of the FPL to have health insurance. Because otherwise, tough. Maybe you shouldn't have had kids. Maybe you shouldn't be a human if you can't earn more than 42% of the FPL, because we're not going to cover you. And I think nothing signifies the candy wrapper being tossed aside quite so vividly as the idea that unless, as a family of 3, you earn less than $8,727 a year in North Carolina, you don't deserve health insurance under our current rules. So Medicaid expansion brings everybody up to 130% of the FPL all the time, with the idea that the exchanges would cover those folks in the gap. So by failing to expand Medicaid and by setting this really low threshold to qualify for regular Medicaid, we've effectively said, if you earn $9,000 a year, that's plenty, you should pay out of pocket. It's also important to recognize that social policies around housing are the reason for wealth gaps that continue to exist today. Richard Rothstein covers this in vivid and exquisite detail in The Color of Law, where he talks about the ways that federal and state housing policy beginning around 1900, deliberately denied people of color the opportunity to buy homes, to get mortgages, and to accrue wealth. And what that means is that today, the average, the median wealth of a Black individual is $11,000 compared to $134,000 for a white individual. What does it mean when your median wealth is $11,000? Well, that means you are really one bad day away from being in a really bad place. And the reason that that situation exists is because of federal policies that were enacted to deliberately deny access to mortgages to folks of color. And this is not just about education. So even if you look at folks with a graduate or professional degree, the median wealth of a white person is $293,000 compared to $84,000 for a Black individual with a graduate or professional degree. So this is the legacy of redlining and of policies that deliberately deny wealth to particular groups. I'm going to make this local for a second. This is a really interesting paper that looks at the role of school policy in contributing to segregation in Raleigh. So this area here with the red box was the middle-class Black neighborhood in Raleigh in the 1920s. And when it came time to build a new high school, the white high school got put right here and the Black high school got put down here. And what that meant was if you were a middle-class Black family whose kids needed to go to high school, they had to be brought all the way down here for their school. And that meant that this was less desirable place to live and those properties lost value. And the result was the segregation of the much greater segregation of Blacks from whites in Raleigh. And when you look today at the proportion of folks with no health insurance, you will notice that this area of Southeast Raleigh that was created by policies that deliberately position the location of Black high schools has caused that area to be the area with the lowest insurance and the lowest wealth. So the bad news is that we did this to ourselves as such. The good news is that we can enact policies to undo this and recognize that it's not the fault of folks living here that they have fewer resources. It was a deliberate plan. And so we need to make a deliberate plan to make it right. The issue of paid leave is one that is particularly galling to me. And I have to pull up this report every time I'm giving this talk or every other time to make sure I'm not reading it wrong. But this is looking at employed women and the amount of leave they took after the birth of a child. And 23% of mothers are back by 10 days postpartum. Not 10 weeks, not 2 weeks, I mean, not 2 weeks is not much better, but 10 days. I mean, 10 days you're still wearing those like mesh panties with the giant pad, right? And you're going back to work. And how can we live with ourselves in this kind of context? So it was fabulous when Governor Cooper enacted paid leave for those cabinet departments. It was fabulous that the North Carolina Board of Governors has done that for the universities in the state, but we need to do it for everybody. This needs to be a thing, right? You just made a person. We think that the perpetuation of the human race is valuable, and therefore we are going to give you support, which you can pay into as an unemployment tax and then get back just like Social Security, and not take your Social Security so you can't retire later. We are going to create a new thing for you because we think that the perpetuation of the human species is worthwhile, and we want to support you. And I think what's especially galling about this is the folks who are least able to take paid leave are those with the least resources. And so, as these two authors write, the lack of policy substantially benefiting early life in the United States constitutes the greatest social injustice. Those who are already most disadvantaged in our society bear the greatest burden. I think that's really important. This is an equity issue. If you are a well-to-do employee of a tech company, there's a good chance you do get parental leave because the tech company wants to recruit you and they need to do that. But if you're working an hourly wage job, you're probably on your own. And we really need to keep that from being forward. I'm going to end this section by lifting up this really fabulous essay by a group of advocates in Shiro's out in California. And they write, there is no answer to solving this crisis that Black women do not already know. It is in their lived experiences and resilience that drives innovation and belonging. And we as stakeholders should take heed. So I think it's critically important as we go to solve these problems that we are sitting down with, engaging and listening to and lifting up the voices of women with lived experience, because I don't have the lived experience to know what somebody needs who lives in a different context than I do. And I need her to tell me, and then I need to say, okay, I'm gonna do that now. As opposed to like, well, I think what you really need is because I'm me. No, I need to shut up. I wanted to share a couple of books that have been really helpful in my journey to begin to understand these issues. I've already mentioned Dorothy Roberts' Killing Black Body. Medical Apartheid is another book that outlines the long history of how the medical system has mistreated and exploited people of color. We've all heard of Tuskegee, but it's a lot more than that. Spoiler alert. And so this is a tough book, but a really important book. Jamil Michener's book, Fragmented Democracy, talks about the role of state Medicaid policies and their effect on people's participation in civic life. And what she finds is the more negative people's experience is with Medicaid, the less likely Medicaid recipients are to vote. So if getting Medicaid means going and standing in a really long line and being treated poorly and being generally felt to be unimportant, people will say, you know, the system doesn't treat me well and I'm not even going to bother to vote. So as a state, we have a lot of issues around voter suppression, needless to say, but it seems that the quality of one's interaction with Medicaid is one of those variables. And so those of us in state health departments and county health departments can really work on making that experience as positive as possible so that folks feel like civil society is something worth engaging in. Reproductive Justice, this is a fabulous book on the bottom left to really get a frame for all the history around these issues. Battling Over Birth was put together out in Los Angeles to look at the different challenges and recommendations that Black women have for how to improve their birth experience. And so before you can be your own focus group, I suggest looking at this as a starting point. And then lastly, Tina Sack's book, Invisible Visits, talks about the experience of middle-class Black women accessing healthcare and the extent to which one has to dress a certain way and act a certain way and acknowledge and convince the provider that one is a well-to-do person in order to get treated like a real person. And I think that this was something that, again, not my lived experience, but it made me aware of the extra steps that folks are taking simply to walk into a doctor's office to make sure that they look like someone who will be taken seriously. And that's work being done by patients that then reduces the other things they can be doing with their time. And it's our job to treat everybody like a human. People shouldn't have to change their clothes to be treated. So in the spirit of asking moms what they need and want, I want to talk a bit about our work with the Fourth Trimester Project. So the Fourth Trimester Project's goal is to change the way America treats new mothers. And we have an active social media presence. Please follow us on Facebook, on Twitter, and on Instagram. And this started out as a Corey-funded project to look at the unmet needs of moms. So our original Corey team includes Sarah, shout out Sarah, wave. Sarah's here, she was holding a baby earlier. Ben Goodman from Durham Connects, I don't think Ben is here. Miriam Labak, who has passed away, but is very much with us in spirit, telling us what to do on a regular basis. Those of you who knew Miriam know that that's true. Monica Simpson from Sister Song, me, and then Kristen Tully, from CGI. And what we set out to do was really ask moms what was important to them. And part of what we learned is that when you ask moms, you want to think about how and where you're going to do that. So our first session, we organized in a hotel conference room, not like this one, and thought, oh yeah, we'll do it at a hotel, that's where you have conferences, right? And we told folks to wear business casual. We recruited moms who were 3 to 6 months postpartum, and guess what? When you're 3 to 6 months postpartum, your business casual doesn't fit, right? And so the mom said, don't tell us to wear business casual. We don't have business casual right now, you know, particularly not with like a nursing bra situation and everything else. So when we had the next session, the moms worked together to design t-shirts, and we all wore the same fourth trimester t-shirt. The doctors, the stakeholders, the community workers, everybody wore the same thing. So that took away this sense of hierarchy that like, well, I'm here in my dress and my pearl earrings, and you're this mom in your sweats, what's up with that? We also didn't do this one at the hotel conference center. Kristen had the brilliant idea to do it at the Museum of Life and Science at a children's museum. So we comped the day for the rest of the family, so grandma or partner or whomever could take the older siblings and run around the museum and have fun. And then we used a birthday party space to convene the moms and talk about their suggestions and brainstorm and do work. And then we served lunch and snack for everybody at the birthday party. So this was a really nice venue. It was a nice thing for the families, and it was also a lot more fun, honestly, and possibly also cheaper than a hotel conference room. Unintended side effect. So I think it's really important to think about when we engage folks. We say, well, we told people to come to the hospital conference room to talk with us, and nobody came. It's like, do you know what it takes to park at a hospital? Go to the hospital conference room. Go to the community. Go to where the folks are that you're trying to reach, and ask their input where they are. Don't ask them to come to us. So some of the themes that came up. This is a moment of levity at the top. This is the baby sleep positions from How to Be a Dad. My personal favorite here is H is for Hell. All the parents in the room will recognize the child managing to take a remarkable amount of space for its size. There's also down here the doghouse where dad is just not even in the room. And then I'm not speaking to you. I like this. Everyone is in a different direction. So sleep is a huge issue for families. And one of the things we heard from the moms in our program was that we need to reframe the discussion about infant sleep. It's about the woman's quality of life too. So we talk a lot about the importance of back to sleep, about separate sleep environments, and then also about the baby sleeping in the same room with the parents. And the AAP recommendation is for the first 12 months, the baby should be in the room with the parents to minimize risk of SIDS. And that is epidemiologically supported. But the reality of having the baby in the room with you for the first 12 months when you have no parental leave and you're trying to go to work every day is that that is not necessarily sustainable. And rather than saying, there is some reduction of risk with babies being in the room, but we appreciate that parents need to function and sleep, we say you should have the baby in the room with you for the first year, the end. And so there's really this need to recognize that there are trade-offs and that mom's ability to function is also an outcome. Honestly, if mom is so tired she can't operate the car to drive the kid to daycare, it might be safer if they were not in the same room, if that were helpful for mom to sleep. We also heard about pelvic floor issues. So one of our stakeholders said, my physical recovery had a lot of bladder incontinence. I kept thinking I'm never going to be able to feel the need to pee again. And so she, I think, had a prolonged second stage. She pushed for 4 to 5 hours. Unclear how often her bladder was empty, but 12 hours postpartum, she stood up to void and peed all over the bed. And her nurse came in and said, oh my God, what is wrong with you? You just peed all over the bed, which is not really what you want to hear when you just were incontinent, which is embarrassing baseline, right? And then she went home and she was still having overflow incontinence, and her OB said, well, you don't have a UTI, I don't know what's wrong with you. You should just keep wearing those depends. So this mom Googled, and she, as people do, and found out that there was this thing called pelvic floor PT, and got pelvic floor PT and became incontinent and stopped wearing diapers. But shouldn't mothers not need to Google to get out of diapers, right? Like, that should not be how this works. We talk a lot about screening for postpartum depression, and we heard from moms of all backgrounds, ages, educations. If I score too high on the EPS, will they send me to an institution? Are they going to take my baby away? And this is particularly resonant for moms of color who may have not experienced the best care in the context of the foster care system. And I, in no way, shape, or form, want to be critical of the fabulous and important work that's done every day by Child Protective Services. However, sometimes communities of color are not treated the same way as white communities. And folks know that, and they make a calculated decision. Is it worth disclosing I'm depressed if that might mean CPS is coming to my house and I have to deal with that? So we need to untangle that so that we're really helping people and not profiling. And then, like a lot of time. And then there's sex. So one of our patients said, not wanting to have sex can put a strain on a marriage, and not all men understand it. And the way a physician says can doesn't mean should. So we always worry that everyone's going to have sex on postpartum decrease, and God, don't let them leave the hospital without contraception. And there are a lot of women who are not interested in having sex at 6 weeks postpartum, much less postpartum day 3. And this particular mom went to her postpartum visit. She's up in the stirrups, and her doctor says, good news, your bottom's healed, you can have sex again. She was like, well, I know that's what my partner thinks is happening tonight, but I think she got down in the stirrups at this point. But I just don't know what to say, because I think he thinks that's going to happen. I just don't want to, and I'm not sure what to do. And her female physician said, well, that's how I felt after my kid was born, and now I'm divorced. Which is not helpful, right? And interestingly, I've shared this story in a lot of contexts, and someone said, well, the reason she's divorced is because she says things like that. Which I think is an excellent point. But the implication was, well, just shut up and put out. And I think we need to be really careful about how we have these conversations and really listen to women and chat with them and be supportive. And I recognize that as OBGYNs, we don't get great training in sex therapy in the postpartum period, but if we don't feel comfortable doing that, we better have a friend in the office who can do it. Because we can't tell mom, well, why don't you I'm going to make a referral for a sex therapist, she'll see you in 6 months. And in the meantime, that's not okay. One resource that they can download on their way home is this fabulous podcast from The Longest Shortest Time. How many people listen to The Longest Shortest Time? So this is an amazing podcast about all things parenting, and as folks passionate about moms and babies in the room, I recommend it to all of you. This particular episode featured Dan Savage, who's a well-known sex columnist, talking about the parent's guide to doing it. And Dan Savage talks about how when his male partner and he adopted an infant, his partner was the at-home parent, was home all day with the kid, and Dan would come home from work, and his partner would say, I have been covered in body fluids all day long, do not touch me! And Dan was like, and this was a real aha moment for me, because I think we think, well, the breastfeeding messes with your hormones, and you're sore from pushing out the baby. No, it's just, I've been covered in body fluids all day long, I don't want to touch anyone. And I think it's really important to acknowledge and own, and talk with our clients and be able to help them realize that there's lots of different ways to do this. And Dan holds that for the first year, if someone really needs it and the other person doesn't want it, that person's got 2 hands, so go to it. And that women and men shouldn't feel like they need to do anything in that first 12 months. The other advice he gives, and I don't think my mom's watching the stream, so I can say this, is that when you do go out on a date night, you should take care of the intimacy before you go. And he says it a different way, but this is the North Carolina Medical Society, so I'm not going to say that. But you should just go ahead and have that time. And then you go out to dinner and you have dinner, and then if somebody eats too much or has an extra glass of wine or the dessert didn't sit well with them, you don't get home and be like, it was date night, what do you mean we're not gonna? Just do it first. This is useful information. So how might we do this better? Well, I think one of the really important pieces is to think about moving away from the paternalistic or even the informative, like, here are your options method of decision making, and instead really embrace this concept of shared decision making. Shared decision making brings at least 2 experts to the table, the patient and the provider. Providers are experts in the clinical evidence, and the patient and her family are experts in their experiences and values. I've used this slide a lot, and I tweet out my slides when I'm giving talks. And one of my colleagues from California said, well, I think you don't have this quite right, because it isn't just the patient by herself. That in many communities, it's not just the patient, it's the patient and family who bring preferences and values to these different considerations. And then there's more than one person on the healthcare team as well. And all of those folks need to be respected and honored. And I try to do this with my patients. We'll be talking through something, and I'll say, well, maybe this would be helpful. And I'll say, but I've known you for 15 minutes, so you've known yourself your whole life. Does this sound right to you? And I really want to own that I know a lot about maternal fetal medicine, right? I took those board exams, I was tortured in Dallas, but I don't know anything about this person, or I know very little about her and her life, and I need to know what's going to work for her. And I think that helps her to realize that she needs to speak up, and I'm going to listen. I was at at City Match last week, and someone said, well, isn't really shared, it's her decision. And we got into an interesting discussion about, well, if I'm a surgeon, is it her decision I'm going to do the operation? I think there's some things that are shared, and then there's some things that are just her decision. And we need to recognize that a shared decision doesn't mean that the patient will share the provider's decision at the end of the conversation. That is not a shared decision. That is coercion being called a shared decision. So when we think about how to apply this in your life, I've tried to get away from this, what do you want to use for birth control question? That's what I was taught to ask at 5 a.m. on postpartum rounds when I was an intern, which was terrible for everyone involved. The 5 a.m. part, the question, the whole thing. But that presumes, number one, that this person is going to have sex with a man, and number two, that she doesn't want to get pregnant again. And in the context of the ways we have coercively dictated contraception for communities of color, if I say to a young woman of color, what are you going to use for birth control? She may hear, oh, you're saying I shouldn't have babies, as opposed to, oh, you're helping me make a shared decision. So I tend to ask folks, might you want to have another baby? And if she says, hell no, then I say, well, what are you going to do for contraception? And if she says withdrawal, then I'm like, well, let's talk about that. Withdrawal and never, don't totally lie, but we'll explore that. And if she says, oh, I want to have another baby as soon as possible, I want them to be close, then I can say, well, we really do think that at least 12 months, ideally 18 months before you get pregnant again is important for your body to heal and for you to bond with this kiddo. And so we really want to encourage you to think about having some space in between. And I had an interesting experience rounding on a patient. I was going through an interpreter, and I might want to have another baby. When do you want to have another baby? She said, as soon as God gives me one. And I said, well, this was 4th or 5th kiddo, I think, that she had gestational diabetes by C-section. And I said, well, we really encourage folks to give your body 12 to 18 months to heal, and you might want to not totally count on God to do that all by themselves. And her partner said, oh, well, I'll take care of it, which I think means withdrawal in that cultural context. But at least we put out there that we had a conversation about birth spacing. And if I just said, what are you going to use for birth control? And she said condoms, and we left it at that, I wouldn't have had that opportunity to share with her that there is an advantage potentially to birth spacing. We can also tell moms what the heck is going to happen to them. So Liz Howell, who's a fantastic women's health advocate at OBGYN up in New York, developed this 15-minute anticipatory guidance, like stuff that happens to you when you have a baby. So for bleeding, she said, you know, most moms bleed for 4 to 6 weeks. Wear a pad, don't wear white, like basic stuff, right? And a social worker who spoke the same language as the participant presented this information, and they made a phone call 2 weeks later just to check in and see how things were going. Well, that 15 minutes plus the phone call reduced depression symptoms out to 6 months postpartum. So just telling women what's going to happen next makes a big difference. And if you think about the amount of prep and information we give folks for, say, having a total knee replacement, and the amount of coaching and the feedback and the PT and all the things, and having a baby, we're like, see ya, take care, you know, make sure you're using contraception. So we can let people know what's going to happen next. There's also a huge role for home visiting, and Durham Connects is a model for this internationally that many of you are familiar with. Durham Connects, every infant born who resides in Durham is eligible for a home visit at 3 weeks by a registered nurse. And the nurses are trained to assess a variety of different domains for mom and for baby. In a randomized controlled trial, they found that receiving this Durham Connect service resulted in higher quality out-of-home child care, better home safety, more community connections, less maternal anxiety, improved parenting behaviors, and reduced care visits. So this is a huge win. They further found that for every dollar spent on the program, $3 are saved in emergency room visits for the infants alone. So if mom and dad know who to call when they're worried, instead of taking their baby to the ER, they're going to get care earlier and more proactively. So as we move toward value-based care, I'm hopeful that the payers in the state will say, gosh, we should really be funding this. Because right now it's funded mostly on grant funds out of Durham, and it's hard to, someone's got to put down the dollar to get the $3 back. And right now we haven't quite figured out how to do that. It's also really important to broaden the lens of what it means for moms to have a good postpartum experience. And Jen Fahey is a midwife out of Maryland, and she's developed these sort of interlocking wheels of things that mothers need in the 4th trimester. I want to focus on these outer blue circles here. She talks about how moms need positive coping skills. So this parenting thing goes wrong a lot. I remember one day I was taking my oldest, who was then a week old, to a doctor's appointment, and I was so proud of myself. I'd gotten dressed, I'd gotten him dressed, I had him in the car seat, and I took a picture of him. This was, no, we didn't have a digital camera, it was a real camera. And I was all proud of what had happened. I'm like, oh, we're ready to go, we're on time. And he proceeded to vomit all over himself, the car seat, me, like, so everyone had to change their clothes completely. But you can in that moment say, I'm a terrible mother, I can't do this, it's all over. Or you can say, wow, this is kind of funny. I'll tell this story someday too. That was funny. Realistic expectations are really important, and that's what Jen Howell's work has shown. Folks need to know, I'm sorry, Liz Howell is a Jen Howell. And then being able to mobilize social support. And this one I talk with patients about very specifically. I think there's a tendency for us not to want to ask for things. And when you have a baby, suddenly you have a 6 to 10 pound, very dependent entity on top of you most of the time. And so you're sitting in the rocking chair holding the kid, and I can remember this happening. There's a pile of laundry, and I'm looking at the pile of laundry thinking, I wish that were folded. And then I'm growing increasingly angry about the pile of laundry. And then, half an hour into ruminating about the pile of laundry, I scream at my partner, like, can you fold the laundry for God's sake? And he's like, what? And if I just said, hey, can you move that laundry so I can't see it? Like at minute 1, it would have been fine. But there's this sense of sort of waiting until it builds up and then explodes. And so we need to, I talk with couples and the mom and her support person about, okay, when she asks for something, go ahead and do it. It may not sound like it really has to happen right now, but she's got a lot going on. And to her, communicate early and often. Don't wait until you're angry. And then the sense of self-efficacy that moms can actually get this done. So it's in the spirit of Jen Fahey and all the work I've been talking about that last week, the 4th Trimester Project launched newmomhealth.com. And y'all have information about these on your tables. And the little purple things are to go on your laptop over the camera so that people can't spy on you. Or more importantly, so that when you log onto a video call, if you are not ready for your face to be on the screen, you will not be. Another adverse anecdote, but I cannot get into that right now. So newmomhealth.com has some core values. We believe that health information should be honest, accurate, clear, high quality, and based on the most current science. We believe that women are resilient, strong, and capable of making quality decisions for themselves and their families. And we believe that communities and health systems should care for the mother rather than demanding that she access care. So the site has extensive content about different issues of importance to moms, and all of this is mom designed. We worked with Meet Standards group at New Mom TV in Greensboro, as well as with Mama's Village in Fayetteville, and with other stakeholders to say, what should these labels be? What should we call them? I think we had perineum at some point. People were like, what is that? So bottom pelvic was the solution. And so Suzanne Woodward and Krista Tully and Sarah Beast are the primary mothers of this amazing resource, and I'm really proud to be affiliated with it. We also talked about the importance of the village. So remember the slippery baby that can't hang on to mama's coat because we are not great apes, or we're not gorillas. Mamas need their village, and so we specifically talk about partners, about family and friends, about job and school and community. So I hope you'll check out this resource and share it widely with your patients. It is free, it is available to all, and we're really excited that it is out there. So in closing, the weeks following birth are a critical period. Our current systems of care do not meet women's needs, and structural racism compounds these challenges. But we can do better. We can share guidance about what to expect. We can ask women what they need and value. We can elevate strengths and share decisions. And we can ensure that every woman is seen, heard, and loved. In the words of Joy Perry, one of my shearers, what would it look like for mothers to not only survive pregnancy, but to thrive? Thank you. Yeah, so the question is, how do you do this in 15 minutes? And I think the first question to ask is, why the heck do we have 15 minutes? I mean, you're right, but that's great. And I think it speaks to the need to think about advanced practice providers to share about midwifery, about centering, which we're going to hear about this afternoon, which is a model that acknowledges that an hour and a half in the waiting room, 15 minutes in a physician's office is not care. So I think that we need to think about redesigning the model. And then I think, I'll try to talk with patients about, gosh, when I see my patients in my breastfeeding medicine clinic, my fondly called Black Castrophe clinic, I open with what's going well. And that's a really important question because if she can't think of anything, that's a specific problem. But it also gives me an opportunity to elevate strengths. And then I say, what are your goals for the visit today? So if we do have 15 minutes, we say we don't have much time today, what's most important? What do we need to take care of today? And then let's come back next week. And well, sometimes when I'm working with the residents and fellows and they have a new patient who has a problem list that is 4 screens long, I was like, okay, we're not going to get this all done today. So I would tell the patient, I understand there are these 18 things we need to deal with. I'm thinking these are really important. How about you? And we'll come back next week and deal with the next ones. But I also think we need to take away this 15-minute thing. I mean, we pay so little for maternity care. If you think about the reimbursement for the global for obstetrics and intrapartum and postpartum care, and what a plastic surgeon gets for sewing up someone's arm in the ER, they're remarkably similar. And so I think we need to decide if we value women and we value children, we should pay for the services that they need.
So remember, you guys have wheels, so we're not reinventing the wheel, we're building upon wheels. So keep a look at the wheels in front of you. And we're going to the one that's about the 4th trimester. So, Danielle, I might need your help. So what we're going to do is we're going to have some time at your tables. You have Post-it notes there. So Danielle, can I still hear you? And we want you to individually think about what's theirs. 3 actions to realize a better future in the area, 2 challenges and enablers to achieve this future, based on some of what you've heard around the 4th trimester and some of those actions. So this is time for you guys individually, and then we'll come together as groups, but if you're already to the second part, that's great too.